the operation of hello hello আছে হ্যাঁ ওইটা চ্যাট করে দিচ্ছি হ্যাঁ 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 hello 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 check hello 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 check hello 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 দেন ও সাথে কেমন লাগাবে आउटवर्ड आउटवर्ड है आउट এই যে আউট লাগান হ্যালো 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 চলছে লাইট কোন চলছে লাইট না বলছে না চলছে 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 ঠিক আছে অনেক hello 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 check hello 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 check hello 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 check hello 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 check hello 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 রাজু ওবে খুলে নিতাম অফ করতাম এটা রাজু তুই ধর জেলাতে হেলো লোক ওই যে চেক করতেছে hello 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 oh hello 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 এই দুপুরে না hello अच्छा दो कैमरे दो हेलो 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 1 2 3 4 माइक्रोफोन टेस्टिंग हेलो 1 2 3 हेलो बियंदा ठीक है नहीं सब लाइन 10 हेलो 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 1 2 3 4 5 6 7 8 हेलो 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 1 2 3 4 5 6 7 8 हेलो हेलो 1 2 3 4 5 6 7 8 हेलो 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 এটা বান্দা লাও हेलो 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 1 2 3 4 5 6 7 8 हेलो দাঁড়া দাঁড়া সুতো দিয়ে আছি हेलो 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 नो 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 हेलो দিছি हेलो हेलो 1 2 3 4 5 6 7 8 हेलो हेलो 1 2 3 4 5 6 7 8 हेलो हेलो माइक्रोफोन टेस्टिंग हेलो 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 1 2 3 4 5 6 7 8 हेलो 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 1 2 3 4 5 6 7 8 हेलो हेलो 1 2 3 4 5 6 7 8 हेलो 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 बियंदा हेलो 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 बिगाजा हेलो बियंदा हेलो 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 1 2 3 4 5 6 7 8 हेलो 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 1 2 3 4 5 6 7 8 हेलो 1 2 3 4 5 6 7 8 हेलो 1 2 3 4 5 6 7 8 हेलो बनबदा हेलो बियंदा हेलो तावलदा गुलदा सबाई हेलो 1 2 3 4 हेलो 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 Hello, 1, 2, 3, 4, 5, 6, 7, 8. Hello, hello, hello. 1, 2, 3, 4, 5, 6, 7, 8. Hello. Hello, 1, 2, 3, 4, 5, 6, 7, 8. Hello. 1, 2, 3, 4, 5, 6, 7, 8. Hello. Hello, hello, 1, 2, 3, 4, 5, 6, 7, 8. Hello. Hello. হ্যাঁ প্রণবদা, হ্যালো প্রণবদা, একটু কথা বলছে। হ্যালো প্রণবদা, হ্যালো হ্যালো। ঠিক আছে, ঠিক। হ্যাঁ হ্যাঁ, পাইছি 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 পাইছি। ঠিক আছে, ওকে। আওয়াজটা বাড়াই কইতো প্রণবদা, একটু জোরে কো প্রণবদা, একটু জোরে কথা কইতা, একটু জোরে কথা কই, একটু জোরে জোরে জোরে। হ্যাঁ, সাউন্ডটা বাড়াইতো না। আছি আছি। হ্যাঁ ঠিক আছে, হ্যালো, একটু জোরে কো, জোরে জোরে জোরে। ঠিক আছে ঠিক আছে, চলে চলে। ও আচ্ছা আচ্ছা, ঠিক আছে ঠিক আছে ঠিক আছে ঠিক আছে। ও একদম একদম, ঠিক আছে ঠিক আছে, দেখতেছি। আচ্ছা, লাইনে থাকো আর কি। এদিকে একটা কথা আছে না, যেন কি হয় না,
যাইতেছে নি ক্লিয়ার যাইতেছে নি
ক্লিয়ার হই, মানে একটু কম যেতেছে, একটু বাড়া জন
কমে গেছে এদিকে
বাড়া জন উপরে উপরেরটা। আছে নি? ভালো আছে না ভাই? ওই জানো না, হারাইছো না? ভালো হয়েছে ভালো হয়েছে ভালো হয়েছে। ভালো হয়েছে ভালো হয়েছে। ওটিরটা মনে হয় কি জানি, বুঝলাম না। এটা অফ করে দিব হ্যাঁ 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 প্রণব দা ঠিক আছে না সব হ্যালো একদম একদম পাইতেছি ওকে ওকে আবার আবার ঠিক ঠিক আছে লাইন ঠিক আছে না সব একটু কথা কইছে একটু কথা কো মোবাইলে চেক করতেছি লাইভে জোরে 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 মনে করছি বলতে জায়গা হ্যাঁ ঠিক আছে ঠিক আছে ওকে ওকে
মাইক অন দে দেবো ক্যামেরা মাইক ক্যামেরা অডিও থাকলে মিউট করে দাও
মিউট 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 ওই যে অফ করে কেমন রে অফ করে কেমন
অন করবো
হ্যাঁ আপনি অন করুন
অফ করে কেমন ভাই
জবাবটা তো আমিও কইতে পারি
হ্যাঁ
ইয়া নেই তো পাওয়া
হ্যালো হ্যালো হ্যাঁ প্রণব দা
হ্যাঁ
হ্যালো হ্যালো প্রণব দা হ্যাঁ কোনা কোনা হ্যালো হ্যালো হ্যাঁ কো প্রণব দা কোনা হ্যাঁ ঠিক আছে হ্যাঁ ঠিক আছে ঠিক আছে হ্যালো প্রণব দা হ্যালো 1 2 3 4 ওকে হ্যালো একটা মিনিট প্রণব দা একটু
হ্যালো হ্যালো পাওয়া যাইতেছে আওয়াজ পাওয়া যাইতেছে সত্যকাম ঠিক আছে ঠিক আছে হ্যালো পাওয়া যায় আচ্ছা ঠিক আছে
সরে যেতেছে এগুলো সরে যেতেছে আমি তো জানালাম বলে এটা তো ডাক্তার কাছে ব্যাটারি ব্যাক আপ আছে নি বিরেন্দা ওই বিরেন্দা এই মনে উল্টা কার এটা ও এটা ক্যামেরাটা ইহানই আছে উল্টা সিস্টেমের মধ্যে এরকম Hello, 1 2 3 4 microphone testing 1 2 3 4. Hello, 1 2 3 4 microphone testing 1 2 3 4. Hello. Hello, 1 2 3 4. Hello, 1 2 3 4. 1 2 3 4. Hello, 1 2 3 4. Microphone testing 1 2 3 4. Yes, sir. Hello, Bianda. Hello. Hello, hello. 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 Hello, hello.
Hello.
Hello. Pranabda, hello, Pranabda. 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 Hello, Pranabda.
सत्तर कहाँ से बोले ऑन से उसके बाद उसको दे देंगे अभी मेरा बात से उनको मैं इंट्रोड्यूस करूँगा उनका बाद दे दूँगा লাগবে হাতে তো কিচ্ছু লাগবে না হ্যালো পড়ব হ্যালো কত উপরে হ্যালো হ্যাঁ হ্যাঁ সারা কথা হইতাছে হ্যাঁ হ্যাঁ হ্যালো 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 হ্যাঁ ও ভাইতাছি তোমার বলা ভাইতাছি কো সারা কথা হইতাছে ডক্টর সত্যকাম কো দো ডক্টর সত্যকাম কো দো হ্যালো ডক্টর সত্যকাম কো দো ডক্টর সত্যকাম Dr. Shattakam? Dr. Shattakam, is it audible?
Audible, sir, clearly.
Okay.
Audible, sir?
Okay, yeah. Are you audible here from the dissection hall?
Yes, sir, very clearly.
Okay. Okay, so soon we are going to start. Our all the setup is ready here at dissection hall, anatomy dissection hall, Agartala Government Medical College. Just in a moment, we are going to start our first session. That is anterior skull-base dissection. So Shattakam, please be there and moderate the session from there. And I believe there are some good number of participants there, sitting there in the halls.
Sir, slowly.
Yeah, okay. I request all the participants who are delegates to kindly be seated in the auditorium, and I request all the moderators, I welcome all the moderators who are here, our faculties, to kindly help our dissectors and observers to learn the techniques well. Please go there. And rest of us will be there in the auditorium, and in just a moment we are going to start. To start with, we have our first dissection will be on anterior skull-base, and with me I have got Dr. Rajiv Kapila from Ludhiana. He is a renowned skull-base surgeon, and he is going to show us the techniques of anterior skull-base. And we have first dissectors, four of them dissectors. One is Dr. Omrit Debarma, then we have Shatabdi Pal, we have Dr. Soni, then we have Dr. Onupama. These four are our first dissectors, and to join them we have four observers, Shantanu, Dr. Omlan, and Dr. Diptanu. Who is that? So I request all of you to be in place. In a moment we are going to start. Dr. Shottokam, over to you.
Okay, sir. Thank you, sir. So welcome all the respected delegates. To our academic
ओके
eminent physical dissection is with us today.
सर मैं अगर एक बैंडेज जैसे बैंडेज होती है ना सर, बैंडेज से इसके हेड को थोड़ा सा इधर को ऐसे टर्न कर दें, ठीक है, किसी भी चीज़ से, तो इट इज़ ऑफ, अभी ऑफ है ना? हाँ ऑन है, ऑन अभी एक बार ऑफ कर दो, विल ठीक ठीक। हाँ हाँ वो सेवलॉन आ जाए, मैं सेवलॉन आ जाए। हाँ अभी एंडोस्कोप फॉगी है ना, क्लीन
क्लीन कर लो ताकि ये जो वेट वाइप है इसको, हाँ इसको सलाइन से वाइप कर ले,
सलाइन से कर लेते हैं। चलो फॉग होता रहेगा।
Sir, can I switch the camera to the main screen, sir?
हेलो, am I audible? Am I audible? हेलो, इधर इस तरफ सर, या लाइक थोड़ा सा इस तरफ को घुमाना। हाँ किसी से अगर बांध दो रस्सी से।
ये कहाँ है? बोलो।
हेलो, am I audible?
Yes, sir.
So, I am Dr. Rajiv Kapila from Ludhiana. First of all, at the outset, I would like to thank Dr. Biplap and the whole team of Agartala Government Medical College for inviting me into this beautiful place and giving me this opportunity for this cadaveric and anterior skull base dissection. So we'll start in couple of minutes. We are waiting for few things. So till then we can start with some orientations, you know. So we have a cadaver here, you can see, and this cadaver neck is turned towards left side, right, you see. So we are trying to move this towards my side. And are you getting the endoscopic picture?
Sir, sorry for interrupting, sir.
Are you
Sound is a bit less, sir.
are you getting the endoscopic picture?
Yes, sir. Endoscopic picture we are getting, sir.
All right, so I am into the left nostril of the patient. You see, so there is hardly any space at present. So you can see the middle turbinate, you can see the inferior turbinate, and there is inferior turbinate hypertrophy here. So there is hardly any space along the inferior first pass inferior meatus, you see. So first of all, the important thing is how to make space when you get such type of a compromised cavity. And if you go on the right side, you see the similar things here, right? You can see it's very stiff. The stiffness is because it's not a very fresh cadaver, that you can again see the middle turbinate here. And so two things, somebody asked me how to make a space, right? So two things that you need to do at the beginning of the surgery after decongestion. So because this is a cadaver, so we don't need to decongest this, but in a live surgery, after you have decongested, you see your anterior end of your middle turbinate, and the first thing you can do is you can lateralize the inferior turbinate. Now where to lateralize the inferior turbinate? So you see the anterior end of the middle turbinate, go a little posterior to this and feel the bone of the inferior turbinate here, all right, and then with the big periosteum elevator you just out fracture the inferior turbinate, okay, like that, all right. So this will create a space for you. This will create a space for you. This is the first thing that you can do. Second thing is you need to medialize the middle turbinate. Now the middle turbinate is attached to the axilla here, and just posterior it's in the sagittal plane. Here it is attached to the skull base. So if we apply too much of pressure here, we can injure the attachment of the middle turbinate at the level of the skull base. So the best way to lateralize is go a little posterior and inferior and lateralize here. Can you see we are getting the space? So you can lateralize here, or you can feel the bone here, and in real surgery you can do a micro fracture of the middle turbinate somewhat here, all right. So where it is turning to form the ground lamella. So very minute micro fracture will stabilize and medialize the middle turbinate, and this way your middle turbinate will be placed flush with the nasal septum. So these are the two steps, two basic and simple steps that you can make your space to after decongestion. Now can I have a probe, please? Probe. Yes, keep the probe here. All right. So now after we have made the space, you can see this is the axilla and this is the lacrimal bone, all right, and this part of the bone that is moving, that is mobile, is what? Uncinate process. This is the free edge of the bone, right. So this is uncinate process. So this is our first corridor that we need to open, right. So this uncinate has basically two parts, horizontal and the vertical. So to do a middle meatus enterostomy, we need to remove this uncinate, only then we can enter the maxillary sinus. Now when we need to enter the maxillary sinus, we need to, this is a two-dimensional space, right. We call this hiatus semillunaris, right. So through this two-dimensional space we enter into the three-dimensional space. See where my probe is going, into the infundibulum. Infundibulum is a three-dimensional space which has our entry to the maxillary sinus or the maxillary sinus ostia, all right. So there are various ways where you can remove this uncinate process. The safest way is the retrograde way, all right. So you take a backbiting and you cut here, engage your backbiting here, and you cut this part of the uncinate, directing it inferiorly, because inferiorly the nasolacrimal duct is little more anterior than superiorly. So, if you take a backbiting here, there are more chances of cutting the nasolacrimal duct rather than taking a bite here inferiorly. So, that is the most safest way. But suppose this your uncinate process is lateralized, all right, and it is so lateralized that you do not find a space here, all right. So, then it may be difficult to first of all put your backbiting here, then you need to find the free edge of the uncinate and try to evert it first. Try to evert it first before putting your backbiting forceps. Another way of doing a uncinectomy is you just remove the attachment of the uncinate process here from the lacrimal bone. You can use a simple periosteum elevator, all right. So, as we do not have a we do not have the backbiting, so I will try to demonstrate it with the Freer's elevator only, right. So, that is your free edge, and you engage your elevator, periosteum elevator. So, do not use any sharp instruments like sickle knife here, because what is medial, what is just lateral to your uncinate process is orbit, yes, lamina papyracea. So, you can enter into the orbit right at the first step if you are not careful, all right. So, you use a blunt instruments like this periosteum elevator. Backbiter, they do not have a backbiter here. Yes, they do not have a backbiter here. That is the safest, that is what I told you, all right. So, when the uncinate process is lateralized, it is very close to the lamina, then this method with the elevator or with the sickle knife can be quite dangerous, because while removing the uncinate you can easily injure the lamina. But sometimes you must have seen, due to the disease, the uncinate process has everted or medialized, it has moved medially and anteriorly due to the polyposis or due to the disease. In those cases, your periosteum elevator works best. You know it has everted, you know where the edge is, you just need to move your elevator here and you can remove this, okay, that is all. So, you just defracture it. So, that is the way. Can you give me somebody give me a wash?
So, sir, in both the ways, uncinectomy can be done, sir?
Yes,
So,
we can do it in both the ways. Suction laga.
First and then give the incision.
Pardon, what are you saying?
So, in both the way, we can do the
Suction. Yes, yes, we can do in both the ways. We can do in both the ways, no issues, right. So, I told you, so be little careful whenever the uncinate is lateralized, all right. So, this suction. So, because when the uncinate is lateralized, it is very near to the lamina papyracea. So, that way suction on karna. So, we will just give a little wash so that we can remove this crust and clean the cavity. Suction on karna. Switch on the suction, please. Just wait, don't put. Yeah, right now put. So, in live surgery, regular irrigation is a very good method to control bleeding, and just warm saline irrigation, that is the best way of controlling bleeding. So, many advocate that they do not give any local anesthesia, but I generally, whenever I feel I have a doubt about it, I prefer to give local anesthesia, xylocan with adrenaline at two places. One is at the axilla and another is at the sphenopalatine foramen area. So for me that works very well. So but again it's an individual choice whether you want to give it an anesthesia. Second is if you get a hypotensive anesthesia, and the third point is the patient heart rate should be low. If the patient's heart rate is low, the bleeding will be less. Okay. Elevator again. Okay. So now you see I am just fracturing the uncinate process here, and this is the vertical segment. So it has come out. So once the uncinate process is out, you can take it out with a debrider or with a true cut forceps. Okay. So we can I straight Bexley's? So because we don't have a debrider here, so I'll just take out with the Bexley's forceps. Can you just catch it? All right. Just clean this forceps. Give me probe now. The long probe. Can you give me a long probe? Yes. So now see. So once we have done the uncinectomy, so this structure that I have opened, see this is what? Maxillary sinus ostia, all right, and this part here is the horizontal process of the uncinate process. See, that's the maxillary sinus. Your maxillary sinus is open, right? नहीं debrider नहीं है. So debrider है नहीं? है debrider? नहीं debrider नहीं है. So we don't have a debrider, but anyhow I'll do it with the simple basic instruments only. So when you don't have a debrider, what you need to do is use maximum of your true cut forceps, straight true cut. All right, so if I can get a scissor also, if possible. So that's the true cut forceps. So you can remove this horizontal process of the uncinate with the true cut forceps. That's it. All right, so you get a good wide middle metacenterostomy now. Give me J curate. Forceps. This is again the bone of the uncinate. So now we have removed the horizontal part. Now we will go to the vertical part of the uncinate process, J curate. Now see, that's the vertical segment. So I'll just mobilize it with my J curate. That's it, right? And I'll just take it out with the forceps, Bexley's. So when you are removing the vertical segment of the uncinate process, you encounter the first and the anterior most ethmoidal air cells. Okay? So what are the anterior most ethmoidal air cells? Yes, Agartala cells, J curate. So Agartala cells are the anterior most ethmoid air cells. Agartala cells are nothing but the pneumatization of the lacrimal bone. You see, this is a hard bone. You see, whenever the pneumatization extends to this bone, this hard bone, right, it is Agartala. and Agartala cells obstructs the frontal drainage pathway. Then you may encounter some cells which are superior to Agartala. All right. So into the frontal sinus, the cells which are superior to Agartala are called Kuhn cells. Kuhn cells may be of different types, type 1, type 2, type 3 and type 4, depending upon their extension into the frontal sinus. Yes. So the uncinate process most of the times goes like this and gets attached to the lamina papyracea. So, and the frontal drainage depends on where the uncinate process is attached. So most of the time, since the uncinate process is attached to the lamina papyracea, the frontal drainage is medial to the attachment of the frontal sinus, the uncinate process. But sometimes the uncinate may go up and attach to the skull base, or it may turn medially and attach to the middle turbinate. In those cases, the drainage of the frontal sinus will be lateral to the uncinate process. So these are the important things that you can recognize on CT scan, on preoperative CT scan. Upturned forceps. This is true cut, okay, but you can upturned forceps be, okay. So I am removing the uppermost part of this processes. Do we have a scissor? Scissor nahi hai? Okay. So now, so there are two ways to approach further straight forceps. So kindly feel free to ask any questions, interrupt me whenever you want. So because the more interactive the session is, I think the more helpful and more informative it will be. So now from here you can approach two ways. So you see the large cell that is posterior to this is bulla. All right. So you can go ahead and remove the bulla, or you can go ahead first opening the frontal sinus in the frontal recess. All right. So those who are comfortable with the 70°, I would prefer those, they should be first doing the frontal sinus work. Because with an intact bulla technique, you can open the frontal sinus with 70° scope, because you will get an angle, right, from here towards up. But if in the beginning, when you are not very comfortable with the 70°, you may remove this inferior part of the bulla, and then later on you can do the frontal work and open the frontal recess, because that will give you a good space and to visualize with the 0° scope. Another tip for using the 0° scope here is, you place your 0° at the floor of the nose and turn it up to see the frontal sinus, right, like this. Okay, so that's why you can make your 0° as 30°. Here because of the patient's neck and stiffness I cannot do, but if you just place your the shaft of the scope on the floor and turn it up, you can make your 0° into 30° and you can see the frontal recess. So maybe I'll use a 70 now, a 70° scope then. I'll use a 70° now and try to open the frontal recess quickly. You see the difference in view now, okay. So this is your view with the 70°, and you have seen the view with the 0°. See how difference and how great it gives. Give me a J curate again. Is the picture clear there?
Yes.
Okay. So that is my J curate, and so if I just, you know, if I open this, these are what? These are Kuhn cells, okay? If I open this, see the structures I am getting now, right? So that's the axilla. You remove to this part and you will get a access into the frontal recess. Can I have a, yeah, I am now using the 70-degree here probe. All right, so whenever you see any opening or any cell in the frontal recess, it is not necessary that that is a frontal sinus. Now, how will you distinguish between a large cell in the frontal recess, which will, you know, which can mimic as a frontal sinus, and the true frontal sinus? All right. So, like this, whenever you see a true frontal sinus, you will not be able to see the posterior boundary. There will be darkness at the end of the tunnel. All right. Whenever you see a cell is a shallow structure, you know. So, this is a cell anteriorly and this is a true frontal sinus posteriorly. See, that's the frontal sinus. My probe is in the frontal sinus now. So, I'll just remove this debris for the sake of exposure now. Upturned forceps. So, are there everything clear till now? So, any questions regarding the frontal sinus opening or drainage? Because it is the frontal sinus, I think that this is true cut, okay? You can give me a forceps also. True cut upturned and true cut forceps, keep both ready. Yeah. Okay, now give me probe please. So, I am still using 70-degree now. So, that is the middle turbinate, right. So, that is our frontal sinus, and this cell I told you it's bulla, small, this smaller probe. So, this middle turbinate, as I told you, it lies in 3 planes. Anteriorly, it is vertical, it lies in sagittal planes, right. And then it turns medially and it lies in the coronal plane to form the ground lamella. And then the posterior most part then again turns to lie in the axial plane. All right. So, this lies in 3 planes, and just anterior to the ground lamella, this we always find a cell, that is ethmoidal bulla, yes. And there is always mostly a space between the ground lamella and the bulla called retrobullar recess, okay. Retrobullar recess, and sometimes, not always, most of the times this bulla, as in this case you can see, it extends till the skull base. It is extending till the skull base, but many a times there is a space between the skull base and the bulla. All right. So, that is what suprabullar recess. All right. So, you can then open this ethmoidal bulla here, okay, and get into the skull base, right. So, that is we are entering the skull base. See how the ethmoidal bulla is reaching till the skull base. So, you can debride all these at this point of time with a debrider. So, because we do not have a debrider, I will take it out with the forceps. Now, one very important thing here is when we are doing the frontal recess work or the frontal sinus work, and the bulla is the anterior ethmoidal artery. Give me a forceps. So, the anterior ethmoidal, straight forceps please. The anterior ethmoidal artery, we all know it lies in the skull base. It may lie in a mesentery or it may lie in a bony canal just close to the skull base. So most of us and initially are very afraid of injury to the anterior ethmoidal artery. All right. So like I have learned and we have been all taught about by Satish Jan Bose. We all have seen his videos, how he preserves the anterior ethmoidal artery. You know, so generally I follow the same technique. So intact bulla technique is a short way to save your anterior ethmoidal artery, upturned forceps. You know, the frontal recess, you know, till you are in the frontal recess only you will never injure the anterior ethmoidal artery. But once you are into the bulla and the skull base, you may injure the anterior ethmoidal artery. So I will try to show you the anterior ethmoidal artery now. I will just take it out for the ease. Just wait. Clean. Okay, so let me clear it now. What we can see is, okay, give me a probe, long probe. Yes, ये बहुत ही long. Okay. So anterior ethmoidal artery, I'll try to clear it for you. So that is again the frontal sinus. All these cells needs to be removed to get a good access to the frontal sinus here. See the anterior ethmoidal artery? Can you see the anterior ethmoidal artery there? That is the anterior ethmoidal artery where my probe is. All right. See how this comes. Anterior ethmoidal artery is a branch of ophthalmic artery. So which is a branch of internal carotid artery? Yes. So if the time permit, I will show you the how the internal this ophthalmic artery arises from the internal carotid artery when we go into the paracellular cavernous sinus. So this is a branch of ophthalmic artery. So
Rajiv, if we want to save this artery from injury, we have to keep the bulla intact.
yes, yes, I told them.
Okay.
I told them, yeah.
Yeah.
Right.
That
So
is
intact bulla
Kennedy.
Kennedy, yes, right. So it enters into the nasal cavity from here, and then it traverses from the orbit. It traverses the the roof of the nose, and then it goes into the intracranial cavity from here, right? And this is this part where it enters the intracranial cavity is the lateral lamina, is the weakest part of the skull base. So this is the most common site of injury when we are doing the FES to cause CSF leak. Yes, please. Pardon? Yeah, so yes, so this structure, this is a mucosal fold, this is a cell, you see, right? Yes, this is a bone, this is not artery. All right, so all these things you can all these things in the live surgery you need to take out, all these cells. All right, I'll try to take it out for you to have a clear view. Give me upturned forceps, yes. Just well, I'll show you. Yeah. So I'll just try to take out all these things. So otherwise, we just use 60 rad debrider blade and debride all these tissues, right? All these cells. So So I am just removing all these cells. And FES we all know is a mucosa preservation surgery. All right, functional endoscopic surgery, we need to preserve mucosa. So I am using forceps here because of the stiffness of this cadaver, but in the live case don't pull here, just use a micro divider or a true cut forceps. Okay, give me probe now. So
hello.
Can you see a wide frontal sinus opening now?
Hello.
That's a wide frontal sinus opening. Even these cells can be removed.
Hello.
I'll just show you.
Hello. So we have just started our demonstration of cadaver, and we are being joined by our principal sir, Professor Anukumar Shah.
Okay.
And with me, I have got my another faculty, Professor Pavan Singhal, who has come from SMS Medical College, Jaipur. Then we have got Dr. Niteshwar Morantham, he is from Imphal. And of course, we have got now, at the moment, we have got 4 dissectors and 4 observers. So the session is on. And I will request Dr. Rajiv to continue for some more time, then we can have a very short our inauguration, which will be done by our head of the institute, Principal Agartala Government Medical College, and then we will proceed on with our hands-on demonstration. So Dr. Rajiv, please proceed. Thank you.
So that's the inside of the maxillary sinus we are seeing. We can remove this part of the bone also to get a wide exposure. So now depending upon the disease, generally this much of middle metacenterostomy is good enough in most of the cases. But in cases of extensive cases, revision cases, extensive AFR cases, we can extend this middle metacenterostomy till the posterior wall of the maxilla. We can do a wide medial metacenterostomy.
Good morning, everyone.
Right?
Is it okay?
And sometimes we can even do a 0 degree.
Yeah. Good morning, everyone. Yeah, I'm Dr. Pavan Singhal. So, Dr. Rajiv is excellently demonstrating the principles of endoscopic sinus and nasal surgery and beyond that on skull base. The thing is, if you don't ask any question, this one-way teaching is of no use. So, I'll motivate the delegates and the faculty and spectators there in the hall to please come up with your questions, queries, so that they can be cleared by Dr. Rajiv Kapila, who is a knowledgeable surgeon. So please use his talent, use his knowledge to quench your curiosity. Thank you.
Clean the tip. So now we have shifted back to 0 degree. I am just removing these septa and the cells here so that we can move further now. Elevator. So you see that is bulla, right? That is still the remnant of the bulla, all right? And posterior to bulla here is our ground lamella, okay? See the maxillary sinus? This is the bulla. Once you go posterior to this is our ground lamella. Now, anything posterior to ground lamella are posterior ethmoids. Anything anterior to ground lamella is anterior ethmoid. So that is the importance of the ground lamella, and that is our I'm sorry, your voice is not very clear. I cannot I'm not क्या कह रहे हैं? Yeah. Okay, anterior ethmoidal artery. So I've told you anterior ethmoidal artery runs in anterior skull base in the area of the anterior ethmoids, or it runs in the roof of the bulla. Okay. So first of all, to safeguard the anterior ethmoidal artery,
one head is having
okay, whenever you say. Abhi? So I'll stop. No problem. So I think there is some inauguration or candle lightning. So I'll pause for some time, and then we'll resume again. Okay.
So thank you, Dr. Rajiv. It was wonderful. Like we are actually sorry to just take a small 2-minute break, so that we are joining with our head of the institution, Professor Uncinate Shah. He is principal of our college, and then we have got associate professor Dr. Pranab Debbarma. He is the in charge HOD of this department. We have a small inauguration where all of us will be joining for 2 minutes. Then you can proceed with the session. Thank you, Dr. Rajiv. Thank you. So, sir,
इसके सुपीरियर हाँ तो आप इसके ऊपर सेल भी होता है कई बार ना सुप्राबुलर सेल होता है इस केस में anteriorly it was reaching.
So it is actually a great session, great moment for all of us. We are all here for our hands-on cadaver dissections, and we have been joined by our principal, Professor Uncinate Shah. Then we have with us we have got Dr. Pranab Debbarma. He is HOD in charge of Department of Anatomy. Then we have got two very renowned guest faculty, Dr. Pavan Singhal from SMS Medical College. He is professor and head there. Then we have Dr. Rajiv Kapila. He is from Ludhiana. He is a consultant head and neck surgeon from there and scalpel surgeon. We have got Niteshwar Moirenthang from Imphal, and of course we have got a very versatile group of learners, four dissectors at the moment and four observers, and of course I'm being joined with my organizing secretary, Dr. Sukumar Debbarma. So far we are doing, I think, a good job, and let us have this session on. So I'll request our principal sir to kindly lead the inauguration lamp, and we can
fan.
Thank you, sir. Thank you, sir, for the honor. I'll request our principal, sir, to kindly just show few words.
Good morning and welcome to everybody. I am very happy to inaugurate this live dissection of skull-based surgery, cadaveric dissection, and with me present is Professor Biplav Nath, HOD, Department of Otorhinolaryngology, and Dr. Sukumar Debbarma, Organizing Secretary, our honored guest lecturer and faculty, and Dr. Rajiv Kapila, then Dr. Pavan from Singhal, and from Imphal, and our own Dr. Pranab Debbarma, HOD of Anatomy Department, and my dear residents and other participants. It is a very good venture from the Department of ENT, and for the residents, you are lucky that during our time of training, there is no such training, because this training, a sort of skill lab, it helps you in acquiring the skill, and I think this will be very helpful in your development of all the skill and becoming a complete surgeon. Hope we can organize this type of workshop more and more, and we can establish our own skill lab. With this few words, I wish all the success of this workshop and hope this will be very much helpful to you all with this. Thank you for the guest faculty again. Thank you all.
Thank you, sir. Now I request Dr. Pranav Devarma, in charge HOD of the Department of Anatomy. With his help and with his cooperation only, we are able to organize this program. I'll request him for a few words from his side.
Thank you, Dr. Viplab. Good morning, everybody, respected principals, and all respected dignitaries and participants. I, on behalf of Anatomy Department, welcome all of you in this 18th Cadaveric workshop. It is our proud privilege to become a witness of Anatomy Department in this workshop. We have very limited infrastructures and resources, but we have tried our maximum effort from our department side to contribute and make a grand success this workshop. First of all, I try to homage all these 5 cadavers and try to thank their relatives to donate their parents and their parents for the academic purpose, which we are utilizing now. Without much delay, I again welcome all the participants from our Anatomy Department side of AGMC and Agartala Government Medical College, and enjoy the workshop and wishing grand success. With this few words, I conclude my speech. Thank you.
Thank you, Pranav. Thank you, friend Pranav. Now I request Dr. Pavan to kindly just share a few words with us about the workshop.
Good morning, everyone. At the outset, I would like to thank Principal Sir for being instrumental for such a great workshop, and the motivating factor, Dr. Biplav, he has taken lead in developing these facilities and doing this 8th workshop there in the department. And I know it is very difficult to organize such a workshop, but he has got a support of such a wonderful team with energetic faculties, like energetic people around, and vibrant residents who are working day and night to make it a big success. I think at this platform, I'll request Principal Sir to convey the message to the government, as I have been striving hard to get the temporal bone and workshops, temporal bone labs and the skill labs there in each and every medical college in Rajasthan. So I am working ahead with that. So I think with the Principal Sir's guidance and his blessings, the ENT department at Agartala is going to have a great skill lab where not only the temporal bone or lateral skull base or anterior skull base can be treated, can be taught and people are trained, but also the head, neck, maxillofacial, microvascular anastomosis, everything is there in our bag. So congratulations to whole department and to Principal Sir, the whole institute, and the state of Tripura, as well as the all North Eastern Association of Otorhinolaryngologists for holding such a workshop. Thank you so much. I will just request participants to please ask as many questions as you want. Thank you.
So, as Dr. Pavan was telling, like it's a teamwork. Now in the team, like the most important member of the team, actually you can say Department of Neurosurgeon. And we have been joined by our consultant from the Neurosurgery Department. Dr. Siddha Reddy is here with us. I'll request him for a few words for the best wishes for the workshop. And he is a moderator of this event also.
Thank you, sir. Good morning all. I welcome all the residents from all over India to this very good skill workshop which is connected in AGMGB hospital. I think this, I think as sir told, skill lab is mandatory, especially for skull base and for lateral skull base, because the number of cases, I mean surgeons who are operating have become less day by day. So all younger generation should learn all the skills and they should utilize all the churches in a proper way. They should get a good training from their mentors. And I thank our principal, our Department of Anatomy, and I think sir, my request is that if we can use the bodies, we can do them C1C2 approaches later on. Today they will do the ENT, at day of tomorrow we can do C1C2 and fixation in these cases, if you permit us. And I congratulate Dr. Biplab sir for taking this initiative forward. Thank you sir, thank you very much. All the best.
I think we are just, this was a short, I am thankful to all our dignitaries coming very early morning, and we'll close our inaugural session of this workshop. In the evening we are going to have our real inauguration session. There we will be talking in detail. So thank you everyone for your participation. Thank you sir, principal sir, and we can get back to our work with our dissection process. Thank you. Thank you.
No, it's okay. Yeah? हाँ पूछो ना. Yeah. Yeah. And no, it will be always posterior to the anterior wall of the bulla. It will be always posterior to the anterior wall of the bulla. So as far as you are anterior to the anterior wall of bulla, you will not damage the anterior ethmoidal artery. First thing. Yeah. Yeah. So you can remove, you start removing down fracture. You go posteriorly and down fracture it, right? So this way you will be able to not go at the skull base first. You remove it inferiorly and medially first, and then you go superiorly and laterally. When you are removing the superior most part of the bulla, there you can be careful to identify the anterior ethmoidal artery. It's in the mesentery. You will see, even in this case, it was not completely flush with the skull base. It was little down. All right. So that is how you see. Even if it is little more down, you will be able to see a vascular structure coming, right? Okay. Okay. So give me a probe. Long probe. Okay, so we first started with the mobilization of the inferior turbinate, then the mobilization of the middle turbinate, then we removed the uncinate process, we removed the horizontal segment as well as the vertical part of the uncinate process, all right. Then we, with the intact bulla, we opened the frontal recess and we opened the frontal sinus, okay. So this is, I am now with the 0 degree, and that's the most likely the frontal sinus. I can, if you want, I can show with the 70 again. So that's the opening of the frontal sinus, and then we moved posteriorly. We identified the anterior ethmoidal artery, right? This is skull base, right? And we removed the bulla, and now we are hang on with the ground lamella. Okay. Now give me a forceps. Straight. Yeah. So now, when you have to go into the posterior ethmoids, what are your landmarks, right? So your first landmark is your maxillary sinus. When you are at the roof of the maxillary sinus, at the roof of the maxillary sinus, go medially. Yes. Right, sir. Hello. Yeah. Yes, sir.
Then we'll allot the after some time when you
So,
decide.
yeah,
then
I'll-
start.
yes.
Then step by step we'll do.
So I'll just do the posterior ethmoidectomy
Yeah.
and open the sphenoid sinus. So that will complete our affair.
One step.
Yes, right. So then we'll move ahead with the skull base, right? Okay. So you the safest point of entry into the posterior ethmoids is infero-medially. You don't go superiorly because there is skull base. This is all skull base, right? So if you angle your instruments up, you can go into the skull base with the debrider with your powered instruments. So you keep your instruments infero-medially and keep your superior maxillary sinus as your landmark, and you enter here, all right. So when you enter here, see my forceps has gone. This structure that you have opened is what? Posterior ethmoids, all right. So that posterior ethmoids are relatively larger and bigger cells. You see, anterior ethmoids are multiple and smaller, posterior ethmoids are larger and fewer. So that's our posterior ethmoids, you see. Now after you have opened the posterior ethmoids, all right, so medially is your superior turbinate. So the posterior ethmoids are bounded medially by the superior turbinate. This is your middle turbinate, and this is, can you see this? This is your superior turbinate. So I don't have a debrider here because in everything which we do is with the debrider. So you remove this part and you partially remove the part of the superior turbinate, and you can directly go into the sphenoid sinus here. So I'll just try to remove this bone and then I'll show you the entry to the posterior ethmoid. Can you clean this forceps? So I'll just remove these steps, forceps here. So in live surgery, you just debride this inferior turbinate and this part, and you keep on going this at this level, right? So your sphenoid os will always be again at the roof of your maxillary sinus. If you go posteriorly here, here should be your where your sphenoid sinus is. See, I am into the sphenoid sinus now. Give me suction. See, my suction is in the sphenoid sinus. So that is the lumen of the sphenoid sinus. Can you see? So I'll make it little more clear later on. So that is sphenoid sinus. So this is what is the lateral entry to the sphenoid sinus. All right. So there is one more way, and the more safer way to enter into the sphenoid sinus. That is medial entry. You can go medial to the middle turbinate. Periosteum elevator. So you follow the nasal septum. All right. You retract your middle turbinate a little laterally. So that's your superior turbinate. Okay. So you go along here and you can enter the sphenoid ethmoidal recess, and you can enter the sphenoid sinus. So that is the medial entry of the sphenoid sinus. Okay. So then I'll just again give me a big true cut we have. True cut, straight true cut, straight. This straight true cut. So you can remove all these cells now. You know where your sphenoid is. Sphenoid gives you a, so anything that is anterior to sphenoid. So that is your sphenoid sinus. What? Oh. So can you see the sphenoid sinus os? That's our entry to the sphenoid sinus. See? That's the sphenoid sinus. Okay. So this all is posterior. This is posterior ethmoid. So we can debride all these cells here. All these cells. I'll take out all this mucosa and the cells to show you the anatomy more clearly.
Hello, Dr. Sotrakam. Can you see? Is visible now?
Yeah, it is visible.
Okay.
So I am intentionally taking this mucosa out now so that you can see the whole of skull base every structure, each and every structure. Give me a wash, please. So this patient has a, I already told you, a little compromised space. Clean the tip. Clean the tip. All right, forceps. So now see your landmarks, okay? Everything is clear. This is middle turbinate. Laterally at 3 o'clock is your maxillary sinus. This white structure, you see this thin papery bone with a yellowish tinge posteriorly is your lamina papyracea. All right, so immediately lateral to this is your orbit. Superiorly what you are seeing is the skull base. All right, and this is your sphenoid sinus. See the sphenoid sinus. Yeah. Low suction. So that's your sphenoid sinus, okay? So sometimes you have a cell like here which lies lateral and posterior to the sphenoid sinus. So that is a noddy cell. Yes? Yes, give me Carrison please. Yes. So when, like if we go for a pituitary surgery, we have to widen the sphenoid sinus and see all the structures that are inside the sphenoid sinus. Now the best way to widen the sphenoid sinus is medially, all right, and inferiorly first. That is the safest way. But you can go laterally also, because anteriorly there is nothing even laterally, so far as you are at the anterior wall of the sphenoid sinus. All the structures, important structures that are there, that lie inside the sphenoid sinus. Now you can see some of the important structures there. So you can see the bulge of the carotid. Can you see the bulge of the carotid there? Give me a probe, I'll mark with the probe. You can see the optic nerve, so that's the anodi cell. I'll show you with the probe again. You see, so that's the anodi cell, all right. So that's the bulge of the carotid, this one. So this goes like this, okay. If we remove this, all these cells, then we'll come to know about the course of the carotid. So to me, most likely this is the orbital apex with the optic nerve, and this is the opticocarotid recess. Is everything clear now? Yes? Right? Anterior face of the sphenoid sinus, okay. Actually, I don't know, there is a problem with the audio visual. Your voice here is cracking, it's not very. Can somebody help in the audio visual, or can somebody tell what is he asking, because nobody here is able to understand what you are saying. Forceps. So again I will remove all these cells. So I have done a wide enterostomy. So another structure which I want you to see is the impression of the posterior ethmoidal artery. That is the posterior ethmoidal artery. Give me a probe.
Hello, auditorium, can you please repeat the question?
Sir, could you please show the ethmoidectomy?
Anterior ethmoidectomy. Yeah, Dr. Rajiv has finished the anterior ethmoidectomy. He will recapitulate.
Anterior ethmoidal artery. Yeah. So that is the anterior ethmoidal artery, and that is the posterior ethmoidal artery. This hole is skull base. Okay. Let me clear it. All right. So you can see the anterior ethmoidal artery. You can see the posterior ethmoidal artery.
Yes, the posterior ethmoidal is very clear.
So all this is anterior skull base. This area between the posterior ethmoidal artery and the anterior wall of sella, this part is, we call
Planum
it
sphenoid.
plenum. Alright, so inside is our sella and this is the tuberculum sella. Alright, so area between the posterior ethmoidal artery and the anterior wall of the sphenoid sinus, or between the tuberculum sella. Between the tuberculum sella and the posterior ethmoidal artery is the plenum sphenoidal. So when there is significant suprasellar extension of pituitary tumor, or there is suprasellar meningioma, or there is suprasellar craniopharyngioma, then we have to extend our approach from transsellar to anteriorly to transtubercular and transplanar, so that we can gain more access to the structure. We can get a more straight trajectory. So this is your posterior ethmoidal artery. Posterior ethmoidal artery is more in the skull base. You have a thick bone here. As we go posteriorly, the thickness of the skull base bone increases. As we go anteriorly, the thickness decreases. And where our anterior ethmoidal artery is, that is the weakest area.
It's
okay?
0.6 mm.
Yes.
Rajiv, can you delineate the anterior ethmoidal artery?
I'll delineate completely with you. Give me 70 degree, please. Yeah, I'm taking a 70 degree, so I'll show for you. Give me upturned true cut. I'll clear more cells and I'll show the anterior ethmoidal artery. So now I'm having a look with the 70 degree. You see, so that's your frontal sinus. Is it clear?
Yes, very clear, Rajiv.
Give me probe. Long probe. So that is your frontal sinus, and that is the area of
the anterior ethmoidal, that behind that, yes, that structure B.
I'll just delineate it.
Yes.
Okay? So anterior ethmoidal artery lies posterior to your posterior table of the frontal sinus. Okay. So now see, this structure is your anterior ethmoidal artery. Yeah. No, this is this is the anterior ethmoidal artery. So see how it is entering. I'll open it for you. Just yes. Give me a true cut. Yes, upturned true cut. Okay, I'll reorient. Yeah. I'll just give me a few minutes. I'll reorient. Okay. All right. Give me probe. So I am, for all who have joined late, we have done a ethmoidectomy. We have opened all the sinuses. We started with lateralizing the inferior turbinate and medializing the middle turbinate. Then we opened the maxillary sinus. That's our maxillary sinus. We did the uncinectomy, and then we have opened the frontal sinus. So that's our frontal sinus. And then we have delineated our anterior ethmoidal artery, and that's our posterior ethmoidal artery. And we have done ethmoidectomy, both anterior and posterior ethmoidectomy, and that is our sphenoid sinus.
Excellent,
All right,
excellent,
so
Dr.
this
Rajiv.
is all with 70 degree. All right, so this upper bluish structure is your sella,
Yes.
laterally is your carotid, and more superior laterally is your optic nerve. Somewhere here. Okay. So the best way to identify the anterior ethmoidal artery is do a frontal sinus opening. You identify the posterior table of the frontal sinus, okay? And anterior ethmoidal artery is just posterior to the posterior table of the frontal sinus.
Yes, yes.
Can you just tell that relationship of Agartala cell and frontal sinus?
Pardon?
Agartala cell.
I have removed the agar cell. Agar cell are the anterior most cell which lie here. Anterior most ethmoidal air cells. They are the pneumatization of the lacrimal bone anteriorly. All
Dr.
right,
Rajiv,
so
can you please clear the frontal sinus area, that mucosal tax?
Yes,
Because
you
it
mean
will,
after forceps?
yes, it will make the area very clear.
Yeah. So I will try to remove all these cells. Here, so because we don't have a divider, so I am having a little difficulty clearing
Yes, yes,
all these cells.
yes. Much better. Actually, that long upturned forceps also really helps.
Yes, it helps here.
In the middle surgery, if the debrider stops working, that is the instrument that we rely on.
Yes. So you can clear all these cells, preserving the mucosa with the help of a micro debrider. You give me a probe now.
Dr. Rajiv, can you please clean the scope?
Yes. Yes. So can you now clearly see? So all these cells can be removed. That's the frontal sinus, okay? That's the posterior table of the frontal sinus. That's the anterior ethmoidal artery now. Is it clear?
Very clear.
So you can now, I have removed the bone, you can see the wall of the anterior ethmoidal artery also. You can see how it is entering the intracranial, going intracranially here. So that is the dura. If a little bit of pressure is applied here you go directly into the intracranial cavity. So
Dr. Rajiv,
dura
can
is
you
very close here. So this
Yeah.
is the thinnest part of the skull base. See your anterior ethmoidal artery now.
So is that a supraorbital cell just above the anterior artery?
Yeah, so this part, if anything that is extending posterior to the frontal sinus, superior to the orbit, that is supraorbital cell. So there where I am going is, yes, you are right, that is supraorbital cell.
Is there any relationship with the supraorbital cell and the position of the anterior ethmoidal artery?
So no, it depends on the pneumatization. If there is a very large supraorbital cell, it can go posteriorly till the posterior ethmoid, till the ground lamella also. In those cases, your anterior ethmoidal artery will be in the mesentery, will be hanging down. If there is significant pneumatization here, you see, if it is pneumatized, your anterior ethmoidal artery will be in the mesentery. Okay, so this anterior ethmoidal artery forms a very tortuous course. I told you, from intracranial cavity into the nasal cavity, from the orbit into the nasal cavity, then it again goes intracranially. Then it supplies the falx cerebri, then it extends anteriorly in the canal, and then it enters the nasal cavity here again to supply the nasal septum and this part of the lateral nasal wall. It supplies whole of this nasal septum. We can make a flap here based on the anterior ethmoidal artery to repair some septal perforations. Then anterior ethmoidal artery comes out here, it supplies the dorsum of the nose. All right, so it has 5 compartments of the anterior ethmoidal artery.
Dr. Rajiv,
Yes.
if there are 3-4 mucosal lines, and what are the best ways, what are the points that we have to see in order to identify the anterior ethmoidal artery? I mean, that separates from the mucosal tags or the mucosal lines, folds.
So you see, the most of the time the anterior ethmoidal artery will be in a bony mesentery. You see the location, it will be posterior to the anterior wall of the bulla. All right, so
Yes.
it will be never in the frontal recess. If you remove the frontal recess, clear the cells before, and while removing the bulla, you are careful at the base of the skull, you can easily identify this anterior ethmoidal artery. Another thing is that suppose inadvertently you injure the anterior ethmoidal artery, right? So most of the time it is not a big problem because it's a small artery, right? So it's, even if you pack here, bleeding will stop. The only problem arises most of the time is if your injury is very close to the orbit here. If you injure the anterior ethmoidal artery very close to the orbit, sometimes it may retract into the orbit. All right, and orbit is a closed cavity which is bounded by bones all around. Even a small amount of 4 or 5 ml of blood is good enough for it to cause damage to the optic nerve. You have to detect that. You feel the tension on the eyeball. If it is getting tense, it means there is some bleeding. Then you have to do some maneuvers. The best thing is, you are an endoscopic surgeon, you have done ethmoidectomy. Give me elevator. All right. So the simplest thing you can do is just remove the lamina papyracea, give incision over the periorbita. All right. So this, can you see this papery bone? So I can easily injure it with my, remove it with my periosteum elevator. All right. So you just remove this lamina and the periorbita and incise the periorbita, let the orbit fall, orbital fat fall into the, so that's the periorbita, right? So
Yes.
that's the fat. Let the fat fall into the orbit to decompress the orbit. So that is the, don't pack at that time because packing will again increase the pressure on the orbit. The next thing you can do is lateral canthotomy. You can just take a scissor and cut the lateral canthus of the patient till you feel the bone. You can do an extended lateral canthotomy. So these 2 procedures can be life-saving for the patient just in case it. Okay, so now it depends on, you can take out the lamina, try to take it out anteriorly because anteriorly there is more fat. As you go posteriorly, the medial rectus comes very close to the periorbita and there is no fat. Okay, so while incising the periorbita, there are chances that you may injure the medial rectus muscle. So that is way. Otherwise, you can extend it till the orbital apex. If you are precise, you can see I have incised the periorbita here and that's the periorbital fat. But if I go posteriorly, little more posteriorly here, then I will be able to identify the medial rectus muscle.
Also, we need to give the incision little inferior, like 1 to 1.5 centimeter below the frontal os, so that the prolapse fat doesn't obstruct the frontal ostium.
Sinus, yes.
Yes.
So it is very important point by Dr. Kishore that frontal sinus drainage should never be obstructed. Even if there is a CSF leak here at the anterior ethmoidal artery, right? And we pack, sometimes we pack, voraciously, very heavily here. What does it happen? It blocks your frontal sinus drainage. It should not happen, otherwise there will be a frontal sinus mucosal. All right. So at the end of the surgery, give me a forceps. Your cavity post fess should be well mucalized. It should be a single cavity. All right. So you should be able to see probably all your sinuses. This is 0. Give me 0 now. With a 0 degree. So you should be able to see all the sinuses and everything with the 0 degree. So that's the periorbita. So like we can see the maxillary sinus, that's the maxillary sinus. We can see our frontal sinus with the 0 degree. We can see all the skull base with the 0 degree. We can see the sphenoid. So this makes sure that when you give washes post-operatively, it will go in all the sinuses from here. All right. So this is the basic FES that we do. I think I can ask Dr. Biplap now whether he wants me to continue or he wants the dissectors to take over.
Sir was telling that we will ask the dissectors to take over and start the dissection.
So there are two options. You can start the dissection. I have completed the FES for you, or I can go ahead with the skull base now.
I think dissection will be better. Dissection.
Okay, so you do this all these steps in your cadaver, try to do it.
So all the dissectors, please go to your respected tables if you are allotted anyone, and we'll start with the dissection.
Yeah.
Do we need to cut or incise the cadaver?
Yes, yes.
Otherwise there is no use of...
Yes, yes, yes. You have need to cut, only then the fat will prolapse in the orbit. No. It's a very good question. So for the orbital decompression, you need to remove the lamina and then give incision in the periorbital. Yeah, so you can give it, posteriorly, you can make a flap, posteriorly maced flap of the periorbita to make it more wide, or you can give incisions also, 2 incisions, join and retract.
40 seconds, actually, just a minute. I will announce the name table wise.
It will stop. You can't do nothing once it has retracted inside. You just wait for it to bleeding to stop. Let the blood dribble out. Come out. It's not a big artery. It's a small artery. And it's not common. Don't be afraid of this. It's a very rare complication. Even if there is an injury to the anterior ethmoidal artery, you can bipolarize it. You can use a cobbleter over it. All right. So it will be controlled. No.
Now we'll start the
never try to
hands-on dissection
back into the orbit.
Hands-on dissection course. So I will declare table wise names. Table 1, Amrit Deparma. Table 1.
Unless the sinus drainage are not
table 1.
Table 1, and Dr. Amrit Deparma.
And observer is
no, it will not.
Monica.
If you keep on suctioning there,
Amrit Deparma.
Poking there. If you keep
and Monica. Table 1, huh?
And
table 2. Table 2.
Dr. Shatabdi Pal.
No, table 2. Table 2. Dr. Soni.
That is for suppose there is a septal perforation.
No. Soni.
Alright, and you need a flap to repair that septal perforation.
Table 2, Dr. Soni, and observer is
along the inferior
Dr.
margin of the septal perforation.
Dr.
Diptanu Saha.
Dr. Diptanu Saha.
And along the floor, you can
table 3.
You can even include the floor.
Dissector is
superiorly anterior ethmoidal base artery.
Yumnam Anupama. Table 3.
You can rotate it and repair.
Observer is Shantanu Saha.
To understand it or not?
Shantanu Saha.
Table 3, huh?
It will be different.
And table 4, dissector,
right?
Shatabdi Pal.
I can show you
and observer,
pen or a paper.
Amlan Deparma.
बस फोन देखना किसका नंबर है रहने दो नंबर है
जरूरी होगा सर तो दिया हुआ है सब दिया हुआ है
नहीं वो आदि का ये करने के लिए
नहीं रवि इनको बता देता फिर अभी तो स्कल बेस करना है
अच्छा वो दे दो ना
वो मुझे 15-20 मिनट चाहिए
सेक्शन नहीं सेक्शन तो जब सब यू हैव टू पुश द
वो डिप्लो बॉट यही कह के गए थे कि वो कर लेंगे शुरू फिर उसके बाद आप स्कल बेस कर लेंगे You see, let's suppose this is your nasal septum. Alright? And this is your plexus skull base. Alright? Now anterior ethmoidal branches are coming like this, right? It are supplying like this. That is what I told you. Now suppose you have a perforation here. Septal perforation. What you will do is, you will make an incision like this. all right, first incision. Then you can extend this incision to the floor of the nose if you want, and you make a posterior incision like this. You raise this flap. Yeah, mucosa and the periosteum, right? You have raised this flap based on the branches of the anterior ethmoid gland. Then you can rotate this flap here and repair this septal perforation. Only a simple single stay suture, that's all. Yes.
The other way around. You have got this rectum coming. This is your environment and this is your flow. So there is a perforation. What you can do is raise the posteriorly raised floor and this lower flap.
Yeah.
From the inferior margin of the perforation. And then just move it upwards.
So,
because this raw area in the floor will heal only for.
So this flap will be based on the branch of the sphenoid artery. This is based on anterior ethmoid gland.
One thing, other thing you can do.
Yes, you need anything? Achha. डिब्राइडर चाहिए था बॉस, डिब्राइडर चाहिए था. डिब्राइडर के बगैर वो उसको क्लीन करना सब कुछ करना बहुत मुश्किल है. ड्रिल तो मैराथन की रखी है. नहीं अभी पिट्यूटरी तो मैं दिखा देता हूँ. पिट्यूटरी तो इट्स नॉट अ बिग थिंग. यू हैव डिब्राइडर इन द ओटी ना? लक्स मिली. तो कितना टाइम देना है? नहीं नहीं अभी फेस्ट के लिए आई थिंक 1 hour फॉर द फेस्ट है ना? हाँ हाफ एन आवर. देन दे विल हैव 1 hour more.
1 to 1:30 would be lunch. 1:30 I will start demonstrating.
So you